I've stood in rooms like this in this building in the past, as part of the acute care hospital industry, as the post-acute care hospital industry, on one occasion, community health centers, and it's an extremely complicated time. We're focused on quality, we're focused on access, and probably in an unprecedented way on the cost of healthcare. And it is a very complicated issue. And when I've stood in these rooms for some of these other industries, I've made points about the unique parts of that industry and what the unique needs were. And those points were always very legitimate, but there are two things that we say in home care that the other segments of the industry, if you will, don't say. They don't have the opportunity to say that. And the first is that we keep people where they most want to be, in their homes, where they can stay with their family members, where they can live and sometimes die with dignity. The other piece of it is that patients, we all know, are getting discharged more quickly, and they're sicker from acute care hospitals. And across the United States, about 29% of all the patients who are in home care will ultimately, during the time that they're cared for, will ultimately go back into the hospital. Their situation, their health status has deteriorated. At organizations like the VNA of Boston and other organizations who focus on this, it's 25%. So that's a 4% which you apply to a large population. That can make a huge difference from a financial perspective. This is an investment worth making. And so, we don't have bricks and mortar construction projects to talk about or R&D projects on new technologies to support. We talk about keeping people home and about saving money. Now, for those of you who may never have had an opportunity to go on a home visit, I'd just like to tell you briefly about one I recently did about 2 weeks ago in Quincy, Massachusetts. We entered a small home of an honorably discharged Vietnam vet who was injured and who was recently discharged from the hospital for an acute care, rather for an orthopedic admission. And as we went in to do the admission, which we knew would take about 45 minutes, I was impressed to see that Pat, our 25-year veteran herself of home care, had to ask a whole series of other questions that were well beyond the orthopedic reasons for the visit. And I noticed, among other things in the apartment, that there was this sort of cascade of prescription bottles, and due to the patient's arthritis, he kept all the bottles open, some of which were spilled over. And in the course of Pat asking this patient, Richard, all about the reasons that he was in the hospital and so forth, discovered that the discharge summary for his medications was different than the one he had been given a couple of weeks earlier from his own primary care doctor. So instead of spending 45 minutes in the apartment, we were there for almost 2 hours. Pat called the hospital, spoke to the hospital staff, then called the primary care doctor, got an appointment the very next morning for Richard, and basically spent about 45 minutes educating him on what exactly he needed to do in order to control his diabetes, which were what most of those medications were for. As we walked out, Pat very calmly, very matter-of-factly said, there's no doubt that his blood sugar would have dropped. Within the next couple of days, he would have been rushed to the hospital, and the ambulance would have gone into an emergency room and would have spent 2 or 3 days in the hospital. So we were there for an orthopedic issue, but it was in the course of this admission that this other issue was discovered. It avoided a trauma, potentially with a very bad outcome, but it certainly saved a lot of money. Pat said this happens all the time. The visits that I've been on since I've been at the Visiting Nurse Association, I've seen this happen all the time. And yet we're here now talking about the fact that there's been a proposal that's been introduced to add a $150 copay to every 60-day episode of care. It's clear to me that Richard was not going to pay that copay. There's just no way. And when I've asked our nurses, I say, what do you think about this $150 copay? We've got nurses who care for some of the poorest citizens in Boston, some of the poorest neighborhoods in Boston, and they say, they're going to prioritize their rent first, their prescription second, and their food third. And if they have $150 left over, they'll get the home care, but they're not going to pay it. They're going to avoid those services. The other set of patients that we care for, sort of the typical patient, if you will, would be in their early 80s. Already 30% of their limited income is spent on paying for uncovered medical expenses. So this is a copay that they're going to avoid, and they're going to avoid the service. And we all know from our own experience within home care back in the 1970s that when that happens, individuals put off they get sicker and then they end up going into the hospital, so it ends up costing money. The New England Journal of Medicine recently did a study of 900,000 Medicare Advantage beneficiaries looking at the impact of the introduction of copays on ambulatory visits. And over the course of time that they looked at this, they found that for every $7,000 that were saved through the use of copays, it ended up costing the system in inpatient dollars $24,000. So it saved $7,000 and cost $24,000. Yet this issue of copay is before us once again. So we would ask for your active support in this fight. We think it's a mistake. We know it's a mistake. It's short-sighted, it's ineffective, and ultimately we think it's cruel. So again, we ask for your active participation in this fight against the copays. Thank you.